Hi, everybody. Welcome to today's panel. Just going to give a minute for everybody to come in, and then we'll get started. Hi, everybody, and welcome to today's panel discussion. I know it looks like we have a couple more people that are trickling in, but I'm going to go ahead and get started because we have a pretty full agenda today. My name is Amy Chan. I'm an attorney with the National Health Law Program, and I'll be moderating today's panel along with my colleague, Alexis Robles-Frede. Thanks everybody for joining us today. As you know, our panel discussion is titled Doulas Know Best, Lessons Learned from California's Doula Pilot Programs. We decided on this title for our panel discussion because in our conversations with partners, both here in California and also across the country, we're working to expand access to doula care in Medicaid programs and beyond. We've really found time and time again that community-based doulas need to be at the table and they need to be leading these efforts. When they're not, the programs are just not successful. Here in California in particular, we've been really lucky to have a very large number of doula pilot programs across the state. So our hope with this project was to really distill some of the information, challenges, and lessons learned from these doula pilot programs. We really hope that the experiences and expertise that have come out of our interviews with the people involved in the doula pilots can help inform the rollout of the statewide doula Medicaid benefit here in California, as well as doula pilots and programs in other states. Above it all, our end goal is really to try to help ensure that Medicaid coverage for doula care is equitable, sustainable, and inclusive, and that it does right both by Medicaid enrollees as well as the doulas who support them. So in terms of what to expect for the agenda for our panel today, our panel discussion is going to start with one question for each of our 6 panelists, and then we're going to move to answering some of the questions posed by you all when you registered for the event. If the transcription, we have a live transcript running, so if it is obscuring your screen or if you don't want it, you can minimize it. Also, the attendees, you should have the ability to ask questions in the Q&A during the panel discussion, but I just want to let people know that with this number of attendees, we have about, looks like 250, almost 260, well, it's like creeping up, but about 260 participants. So in all likelihood, we're not going to be able to answer all of the questions. We will save the Q&A afterwards and try to circle back with our panelists and see if we can get them, see if we can send out a response to some of those. But just to note, we're not in all likelihood going to be able to get to all of the Q&A that do come up. Also, please note that some of the questions are likely going to be answered in the draft documents that we emailed earlier this week. So the one was the summaries of California doula pilot programs, and the second was the challenges reported by California doula pilot programs. With reference to those 2 documents, we really hope that you had the opportunity to review both of those documents, since today's discussion will focus specifically on lessons learned. So we're not going to be covering the scope or details of the doula pilots today, since that was covered in the summaries document. We're also not going to review the various challenges the doula pilots face during their launch and implementation. That's covered in the challenges document. Both of those documents that we shared were in draft version. We will be sharing the final versions of these documents with all the attendees who registered. Lastly, I know this question will probably come up. This panel discussion is being recorded, and the recording will be shared out with all attendees afterwards. So let me see. We are joined today by 6 amazing panelists and our visual scribe, Ashanti Gardner. Our panelists will be sharing their lessons learned from launching, implementing, and leading some of the doula pilot programs that have taken place here in California. I want to note that the panelists today represent some and not all of the doula pilot programs that we interviewed as part of the project. There were also some doula pilot programs taking place in the state that we were not able to interview as part of the project. In selecting the 6 panelists today, we were really hoping to achieve a mix of perspectives in terms of geography, payer, and also program diversity. So as I mentioned, we are joined today by visual scribe Ashanti Gardner, who will be creating a visual representation in real time of the panel discussion. I'm going to hand it over to Ashanti now just for a few moments so she can explain her process and how she'll be capturing the discussion today.
Thank you, Amy. Hi, I'm Ashanti. So I am a visual scribe, also known as graphic recording. And essentially that is just coming into the room as a neutral witness and capturing the discussion using graphics and words. And at the end, what you have is a visual, which is another language, right, of your conversation. So you can see the connections, you can see where their synergy was in the room. And so it's just a really great artifact to reflect back on and to share out with others. Thank you.
Thank you so much, Ashanti. I'm really excited to have you here today and grateful that you're going to be able to share your time and your work with us. So with some of the housekeeping out of the way, we can finally start. I know we have a lot of ground to cover, so let's just jump right in. I'm so pleased to introduce today's panelists. I'm going to go through everybody's biography, quick bios, and then we'll jump into the questions. So, I know the order might be different on people's screens, so I'm just going to do the bios in alphabetical order. So Marna Armstead is a doula, owner of Marna Mama Doula Childbirth Services, and co-founder and executive director of SisterWeb, a community doula network in San Francisco, California. Marna participated in the San Francisco Department of Public Health SisterWeb and Expecting Justice Doula pilot program. Welcome, Marna. Dr. Priya Batra is a physician, specifically an obstetrician gynecologist and senior medical director of the Family and Community Health at the Inland Empire Health Plan. Priya is participating in the Inland Empire Health Plan Riverside Community Health Foundation Doula Access Pilot. Welcome, Priya. Deidre Kutsumpos is a doula program coordinator and doula trainer. She co-founded the Sankofa Birth Workers Collective of Inland Empire. Deidre is participating in the Riverside and San Bernardino County Perinatal Equity Initiative Community Doula Services Programs and the Doula Access Program pilots. Welcome, Deidre. Linda Jones is a doula and owner of the First 6 Weeks Doula Service, as well as a co-founder of Black Women Birthing Justice. Linda will be the doula program coordinator in the Alameda County Public Health Department Experienced Doula Access Pilot Program. Welcome, Linda. Caffrey Riley is a doula, maternal infant educator, and prenatal yoga specialist, in addition to being owner of the Los Angeles Birth Partners and co-creator and joint director of the Frontline Doulas, centering the community program in Los Angeles County. Caffrey participated in the HealthNet Doula pilot program and is currently with the Blue Shield Doula Community Health Advocate Program. Welcome, Caffrey. And Michelle Sanders is a doula, lactation educator, certified surgical technologist, and founder and executive director of Beauty for Ashes Maternal Wellness, Inc. Michelle participated in the Los Angeles County Department of Public Health African American Infant and Maternal Mortality Pilot Project as the project coordinator. Welcome, Michelle, and welcome to all 6 of our panelists. So we are going to go ahead and get started. So as I mentioned, for this first part of the panel discussion, I'm going to be asking each of the panelists one question, and then we're going to move on to the sort of Q&A. So my first question is for Kefri. Kefri, can you talk a little bit about what aspects of community-based doula care can integrate with systems of health coverage?
Yes, hello. I'm coming to you from the land of the Tongva people, otherwise known as Culver City in Los Angeles County. I want to say hello to everybody here, these beautiful esteemed panelists, warriors, and thank you for having me in the Frontline Doula program here today. What aspects of community-based doula care can integrate with systems? Okay, integrate or cultivate is what I kept bringing up here in my mind and in my heart. Integrate or cultivate. And I want to share a quote from a great one who's just recently transitioned, the Buddhist monk and peace activist, the Venerable Thich Nhat Hanh. And he said, Freedom is not given to us by anyone. We have to cultivate it in ourselves. He says, when you eat, eat as a free person. When you walk, walk as a free person. When you breathe, breathe as a free person. And this is possible anywhere. And I humbly add, when you birth, birth as a free person. And I'm interested in integrating that freedom, fearlessness, peace, joy. We have to cultivate this freedom in ourselves, and anything less than birthing free is unacceptable. And I think we're kind of fooling ourselves a bit if we think we can fully integrate into the medical industrial complex. I think that we can self-determine what this birth work looks like to our communities and how we want to, and we have the choice or don't want to work in healthcare systems, what our professional rates are, what our preferred business models are, what our personal practices look like. So I do think we can upload and collaborate, dismantle, co-create, disrupt, download. I don't know if there's any real integration, but there's cultivation, accountability, change, upholding cultural competency, evidence-based care, community care, and empowerment so that our birthing families can claim their human rights at birth. And I don't think we can wait till we're fully integrated. It's not going to happen. So we have to do this for ourselves first and now. And that's what these community doula programs represent, us doing it for ourselves and collaborating and reimagining what doula and birth worker care can look like within healthcare systems and outside of systems, because the doulas, I think we flourish the most outside of systems. That's why we're here now. That's why this current zeitgeist is in effect, because we're here outside of the systems that basically are causing the harm. However, we will bridge build and co-create and plant seeds with the funders, the insurance companies, and with these amazing people here and all the stakeholders and activists that are on this call, finding the right ways to bill and to code to insurance companies. And, it's kind of like a double-edged sword because it's very litigious and heavily regulated. And so how will this be different than the last time and what history has shown us, right? When the Black and Indigenous grandmother midwives were regulated and then put out of community care models and hospital systems simultaneously. So I say there's no integration, but there's bridge building. There's seed planting, there's cultivation, and there's this insistence of compassionate care together. So, and this advocacy aspect is the most fundamental aspect. And ironically, that gets the most pushback from the systems that we're trying to so-called integrate with. And the most pushback even from the Western-based doula training models, right? But we don't believe that, but unfortunately, this is kind of like a common theme that we're constantly having to stand up against. So, but to answer the question simply, yes, we can cultivate and utilize birth work within all systems of healthcare. So that's full spectrum birth work. That includes preconception, fertility, abortion, miscarriage, stillbirth, lactation, body feeding, infant feeding, birth and postpartum care. All aspects of doula care can be billed. I mean, we can send the invoice and we can get paid. I think the grandmother midwives have already sent the invoice. We're just here collecting at this time. But then I want, then there's the more traditional, holistic, culturally specific care, the birthing rituals, the ceremony, placenta encapsulation, birth care as a ministry, the herbal remedies, adornment, dance, ministry as song and hands-on healing. I don't know if we need to integrate these cultural inheritances into the systems per se, or should we expect them to? So how can we keep those cultural inheritances intact and at the same time integrate? I don't think so. So that's a question for us all. But anyway, we give care. We give preventative care. We give evidence-based care. We give allied health service care. We can bill for that. So as we create these billing codes and figure out ways to do this, I don't know if it's going to be fair. I don't know if it's going to be equitable. It probably won't. Probably come with a lot of problems. And so I think in order to cultivate this care and compassionately collaborate, community doulas must be at the table when these plans are being made. We have to cultivate this together for the better outcomes that we want. And that's at every single step of the implementation of doulas within healthcare systems. Birth workers must be present and we're not going anywhere. So get ready. We're here and we're not going anywhere. So yeah.
Thank you so much, Kefri. My next question is for Linda. Linda, can you explain the importance of an adequate reimbursement rate for doulas for equity and sustainability?
Hello, everyone. Thank you for having me, Amy, to join this illustrious group of amazing, fantastic people that I know so well. that question is almost the, bedrock of this whole program, because we've been doing this work for a really long time, and many of us have done it for free because it's hard work and it's work that we love to do and we know it needs to be done. And we've always said we want to do it, but we'd like to get paid for it because it's hard work. Being a doula is nobody's walk in the park. We do a lot. It's physical, it's emotional, it's availability at all hours of the day and night. And no one else in that whole spectrum of perinatal care is with the person more than the doula is when we're hired to be with them. So we need to be compensated for that. And we need to be compensated at a living wage, because unlike doctors or anybody else in that realm, we can't take on 50 clients and get paid, $500 per client. We can't take that many people. We can do maybe 1 or 2 births a month without being totally fried and burned out. And so because of that limitation, we have to get paid accordingly so that we don't have to have 16 side hustles going on to be able to do the work that we love to do. And that looks different in many places in this country. But when we're talking California, everyone knows that California is probably the most expensive place to live in the country, especially in the Bay Area where I am, in Marna. We need to be able to compensate people to do this work and do it at an equitable rate. And that seems to be a real sticking problem with a lot of programs. I remember when I heard about the first Medicaid program, I think it was in Wisconsin or Michigan or someplace. And they said, oh yeah, well, we're going to pay them $300. I'm like, wow, that's not going to fly, and these programs could be really, really successful if, as Kefri said, they keep the doulas at the table from the beginning until it's implemented and listen to what we're saying, because we know how this works. I've been doing this over 30 years. Many people have been doing this for many, many years. And so we know how to make it work and how to make it successful. And doing this hard work for free is not going to make it successful, or making it the pace so low that we aren't going to be able to get people to join the program. It's going to make the program not successful, because no one in the Bay Area is going to sign up to work with people and get paid by Medi-Cal or Medicaid really small amount of money, because we can't. It's just impossible. This is not minimum wage work. So we have to have people realize that this is a profession, and just because we aren't all going through, a master's course in doula to become that, because it's not necessary, because of the way the work is done. But you have people who are totally experienced, totally knowledgeable, willing to do the hard work, willing to get up in the middle of the night, willing to be with someone for weeks after they're born, their babies are born, to make sure that they're healthy and safe. So I want to make sure that when these programs are being looked at, from the very beginning, when you're making that first budget up, don't lowball the number. You need to make sure that the number, you look around wherever it is that you're living and see what it is that doulas are billing as a private individual, and see what that is, and then come close to that if you can't at least match it. We had that going on here when we talked to Alameda County, and we're talking with the doulas, and we just said, no, we can't work for a really low rate. We have to do it. And they heard us. And so we're going to probably be making more than most programs are, but it has to be done to get the work done and to get people to join these programs, because the work that we're doing is so essential to keep Black women and birthing people alive. And it's not us that, as Kefri said, it's not us causing the problem. We're out here beating ourselves up trying to get these outcomes to be better than they are. So I'm just hoping that everybody, the funders, all of them listen to the fact that this is professional hard work, and it needs to be compensated the same way. Thank you.
Thank you, Linda. Our next question is for Marna. So Marna, the Sister Web Expecting Justice pilot in San Francisco had started with doulas on an independent contractor model and then ultimately shifted to a model where doulas were employees being paid a salary. Can you talk about what went into that decision?
Absolutely. I want to first acknowledge that I'm coming to you live from San Francisco, California, and the traditional homeland of the Ramaytush Ohlone. So I want to honor where I stand and where I am a native of and proud of it. So going to independent contractors to employees, when we first started planning Sister Web, we knew right away that we didn't think an independent contractor model would work for our program. And I want to acknowledge that we are now employing our doulas full time, and that is not everybody's model, nor is it, always possible. It can be difficult getting the funding. But the reason we decided that we needed to move from independent contractor to employee was because of the sheer amount of work that our doulas had to do. They work in a team of 2 or 3, so they have partners, they have backup doulas in their team. They all do have a primary client, and they kind of back up for their teammates. And we found that to be a way to share the burden of caring for the client and being the one on call and on the berth for, hours and hours and hours on end. So we allow for the teams to pretty much decide how they want to care for the client. And as we started to even work with our doulas, we noticed that there were so many other things that were happening that were taking up time that they weren't being compensated for. And they needed additional supervision. They needed mentorship. They needed ongoing training about what's happening with their client. They had, issues balancing their workloads. A lot of the time doulas have a regular job, and then they kind of side hustle their doula work, right? And we were kind of asking for a shift, but it wasn't enough money to really make them shift. So they were continuing to work 2 and 3 other jobs while they were getting an independent contractor fee from us. We also saw that the course of care could be 3 to 4 months. And, our reimbursement rate was a certain amount, but it didn't really, that was still too small to cover 3 or 4 months. If you're trying to live on, a couple $100 or even $1,000 over the course of 3 or 4 months, it's not going to work. And I want to call back to Kefri and Miss Linda that it's hard work. You know what I mean? You can only do so much as a one person, and that's, doula work is very hands-on. You have to physically be there with the client. And even during COVID, there has to be some point where there's physical interaction, and you can't shift that. So we looked at all of these things, and I'm taking some notes here. And we found that it was just not fair, but we really didn't have enough money. So I and my team decided that we're just going to go out and try to find more money. And we were able to do that. And I'm saying that because Sister Web is coming from a place of privilege. We got a significant amount of seed money, and we were also able to work with our city. San Francisco City and County was very supportive of us. So by the time we got to COVID and we were locked out the hospitals, and then we were expected to come back in, and we were looking at what if our doulas get sick? At the time there wasn't a vaccine. And we're paying them a fraction of what other medical providers are getting. So we decided we were going to push to bring them on as employees, provide benefits for them, medical insurance, sick leave, all of those things that are really important, and shift them so people would be able to move from juggling a bunch of jobs to working for us and getting a dignified wage. And that's what we're achieving today. Thank you.
Thank you, Marna. Our next question is for Priya. So Priya, as an OB and also an advocate for expanding access to doula care, can you speak to how the medical system can help to build trust and also be better partners with doulas who are working in healthcare settings?
Yes, thank you. Good morning. So I think first, and I've said this before, a lot of what, or really essential to what doulas are providing, or we're asking them to go into these systems, medical systems, hospitals, that are traditionally very unfriendly, right, to the way that they care for birthing people, unfriendly to models that aren't very medical, right, traditionally medical in terms of care. And so what we're really asking doulas and their clients and families to do is really work on system change. And that's like a hard job. That's like, I think we've heard the phrase like heart work used, right? That is really hard. That is a big challenge. And so because we're asking that, I think it is like critically important that medical systems, payers, physicians like me, other health professionals, welcome, doulas and their clients and families into our spaces, like recognizing that they are doing the work, right? They are doing the system change. I think more concretely, really welcoming and kind of bringing doula work into our spaces. It's like incumbent upon us. It's like in the scope of medical care. So I mean, a lot of, right, think about how healthcare progresses. Like we're all the time looking at, oh, here's a new intervention, here's a new model of care, like here's something promising from another space that really could improve outcomes for our patients and our clients, right? So we're asked to do that all the time. So how is this any different, right? If we see something promising and like that improves patient experience, that improves patient outcomes, we as a healthcare system, just like any other innovation, should really be welcoming it, right? And helping it thrive, and then evaluating and seeing like, does it work as well as, Kafri pointed out, does it work as well in the system as we know it seems to work outside of the system, right? So I think one, just recognizing that doulas are doing so much and like really agents of change, right, in the system, and then welcoming that, innovation and new perspective in, because as I think many people have already pointed out on this panel, we're not achieving equity and good outcomes going the way we're going, right? Even in places like California, where we, lead in terms of decreasing maternal mortality and severe maternal morbidity, and, our, infant outcomes may be better than other places in the country. There are huge disparities when you look closely at the data. Folks with low income, folks who identify as Black or African American birthing people, Native birthing people, right? They're not sharing in those gains, right? So if we see something promising, we should be welcoming it in, right? And saying, how can we support this? How can we learn from what you're doing? So, and I think that's like totally in the scope of healthcare. That's what we do every day with innovation.
Thank you so much, Priya. My next question is for Michelle. Michelle, the Los Angeles Department of Public Health AIM pilot and many of the other doula pilots who were interviewed were focused specifically on Black pregnant women and birthing people. Can you share about your experience in focusing on delivering doula services to Black pregnant women and birthing people?
Well, I mean, the experience was, to just put it like one single word would be phenomenal, right? And reason being is because like this is what we've always done. And now we have a spotlight, right? To show people how we take care of ourselves, how we take care of each other. I know that this question is still a question that gets asked all the time, but why, right? Why is it exclusively for Black women? So over the 2 years that I was the program coordinator for the AIM Doula program, we would still get people who would say like, okay, well, this mom does not identify as Black or African American, but she really needs a doula. And I totally understand that. And I believe everybody should have a doula, whoever wants a doula. Even if you don't want a doula, you probably just don't know that you need one. We understand that Black women and babies die at a higher rate than other, ethnicities. So we know that if we can improve these outcomes for Black women, everyone else will benefit, right? And so when we look at like other situations or other issues, targeted universalism comes up, right? And it's the same thing, right? So if we target Black folks who have the worst outcomes and improve that for them, everybody else will see an improvement. Versus like Dr. Batra said, we are seeing improvements in California, but not necessarily in our demographic. And the reason why is because, racism is still so prevalent. But You know, some of the things that I saw that I don't think other people realized, you know, we understood the assignment, right? The doulas who were working on the program, the community, where, you know, people were like, I'm wondering, like, is this going to be successful? Are people going to come? Like, do you think people are going to participate? And I never doubted that people would come. And so, you know, our target for the pilot, I believe, was about 360 families that we, you know, wanted to serve. And of course, we exceeded that. And then we had a wait list. And the demand stayed high and just increased, you know, as the word got out about the program. And so what that showed is that this is what we want. We want to be in spaces where we feel safe, where we feel supported, where we feel seen and understood, and where we don't have to explain, like, you know, the nuances or, you know, certain things about what it is to be in this Black body. And so therefore, you know, we had repeat clients come through the program, you know, a lot of COVID babies. We had doulas in the program also come through the program and have a doula, but we saw sisterhood, right? And it's like, you know, we're not biological sisters, but we as doulas, we doula each other. We took care of each other, you know, helped each other. You know, we saw doulas kind of integrate into people's families where, you know, this happens in private practice where you get really close to a family and, you know, they invite you to, like, you know, celebrations, the baby's first birthday and things like that. And so, you know, people were so happy to be able to receive this service. And, you know, just understanding that coming into this program to get this free doula support did not necessarily mean that you were low income, did not necessarily mean that you couldn't otherwise afford doula service. You know, I would tell people who would call and say, well, I'm not low income, so how much does it cost? And it's like, no, it's still free. Because I don't care what your income is, having a baby is expensive, right? I don't care what race you are, having a baby is expensive. So you can save your money for something else. And then understanding when you go into a hospital, I don't care if you have a PhD or whatever, any letters behind your name, you are still a Black woman who probably will not be treated the same way as a white woman would. So you're still at risk. And so the program was open to everyone, regardless of income, regardless of gestational age. So people came in really, really early in their pregnancies, and some people came in post dates, and we still gave them a doula. And what we saw was no matter when people came in, it was still beneficial, and no matter what the outcome. So we go in, you know, expecting a vaginal birth, but we end up in a cesarean, and the client was still happy that they had the support that they needed. They still felt supported. They still felt like they were prepared and they had an advocate, and they, you know, did what they needed to do, which was birth this baby. And so I think that, you know, we all grew, myself, the doulas who worked on the program, and the community that reached out for services. You know, some of the moms that came through our program later went on to train and become doulas themselves.
Thank you so much, Michelle. Deidre, what are some ways that both you and the Sankofa birth workers have been able to build in just ways to support the doulas who are providing the service in both Riverside and San Bernardino counties through various issues that come up for them, for example, racism, vicarious trauma?
Thank you so much, Amy. And also thank you to all of the other panelists for creating the space and sharing your learnings. What we were finding in our programs, as it's already been stated, doula work is already hard work when circumstances are at their best, or what some people might deem at their best. You know, showing up, being present, being on call, giving education, reassuring families, and giving them all of the information they need in order to navigate the system. But our doulas were also encountering families that had a higher level of psychosocial needs. We've had families that have been unhoused, families with incarcerated partners, families who are just experiencing above and beyond some of the, I'm going to put these in, common challenges that a birthing family might experience. And this was taking a toll on our doulas as well. And so one of the things that we've implemented in order to combat vicarious trauma. And really, vicarious trauma is trauma that's not processed, or if a person has to hold on to that and they don't have a place to work through it, to talk it out with someone else, this is when it becomes embedded trauma in an individual. So we create space. When we were setting up our program for the Perinatal Equity Initiative, myself and my co-leader divided up our doulas in 2 groups, and we mentor each of those groups. And every time one of our doulas attends a birth, we ask to debrief with them after, or encourage them, if they are finding challenges while they are serving parents in the prenatal period, encourage them to talk to us, and we can kind of brainstorm together, think about resources of how to actually serve the families, and really show up and listen to and care for these families who have high needs, instead of having to hold that in themselves, and then being able to show up. So in addition to these individual check-ins that we have each time our doulas have clients, we also create a space monthly for the doulas to share together, for us to do case conceptualization. Sometimes we'll bring case studies and hypothetical situations to the table to talk about, how do we troubleshoot? How do we take care of ourselves? How do we know when how serious an issue can be? In addition to that, our counties sometimes have trainings that our doulas can go to in order to, how do you support somebody who might be experiencing domestic violence? How do we identify what emotional abuse looks like? How can we really note these things so we can kind of separate them from ourselves and not take it all on to ourselves as a doula, as an individual. Also, within our large of the Sankofa Birth Workers Collective of the Inland Empire, we have a large network of members who we have community share times where people share their own skills and talents that they are building up, whether that's ways to take care of our bodies, doing mindfulness practices. These are places, these are resources that our doulas can tap into in order to help combat vicarious trauma, and then also identify when racism, even if it's very slight or microaggressions, are happening, so they can be validated in their experience and also help work through the experiences that they have.
Thank you so much, Deidre, and thank you to all 6 of our panelists for answering all of those questions with such thoughtfulness and grace, and just sharing your expertise and wisdom. I'm going to pass it over now to my colleague Alexis for the second portion of our panel discussion.
Thank you so much, and thank you for your answers already, and thank you for those of you who are putting questions in our chat or in our Q&A. So I'm going to open it up for more of a conversation format while we get to some of the questions that you all submitted to us in your registration. So first, I'm going to ask, do any of you have any advice for recruiting and training doulas from communities of color, limited English proficient communities, and rural communities? I see Michelle.
Yes, so one of the things that we did with the AIM Doula program is, in our budget, we had space for trainings. So not only continuing education and training for the doulas, we also opened up some seats to community members. So like I mentioned before, a mom who came through the program later went through one of those trainings that we sponsored that was free to become a doula. But we know that a lot of people go through doula trainings. It may be a weekend, it may be a week, but then they come out and they're like, now what? You still don't have the experience. You still don't know what to do. You still don't feel like a doula. So I decided that we should implement a mentorship program. And so we had these people who trained through these free doula trainings to now come in and mentor with these experienced AIM doulas. And so now they're getting the hands-on training that they need, because we don't want a doula to be shell-shocked going into supporting the community, because it's not helpful for anybody, right? And so, the doulas are learning how we worked at DPH to do the paperwork, to do the data collection, and all the meetings and things like Deidre mentioned that we have to do. And so they were able to learn it this way, which is not the traditional way that we do it. But this is because we needed to have more people to choose from when we're expanding. And what we found was that, most of the people who would apply were not experienced. They took a training, but they had not actually supported births. And so this was the way that we decided to train people and have them ready to hit the ground running.
Thank you. Deidre?
In our area, we also have similar trainings to what Michelle was describing. One of the things that we also have found helpful in order to create space for people to want to come and to people to feel like they can be most at home is that we're doing our best to create culturally congruent trainings as well. So in our community, we have a Black community doula training that works in partnership with the Riverside Community Health Foundation and the Sankofa Birth Workers Collective. But we've also been able to provide Spanish speaking doula trainings that we are coordinating with another organization in the community that serves professionals, that serves the Spanish speaking community as well. So really, and making sure that every entity that is covered from somebody who is working with and in those communities, so they can speak from their individual experience to give the trainees a holistic perception or perspective of what this community is like and what these particular community needs are as well.
Thank you both for that. Another question, and this is a big one, but a very important one. How do you build doula programs that address individual, structural, and institutional racism, not just for the clients, but also for the doulas within the programs themselves? Marna?
One of the ways that we have been able to begin to tackle that is that, so Sister Web is an independent organization. We work in conjunction with our city and county and other community-based organizations. And in the city and county, we have partnerships at all of the birthing locations. So at every hospital, and we have one birth center in San Francisco, and we've been able to create a partnership. Now, again, that this is difficult, and we had some support in introductions, but we have an opportunity. We called it the Champion Dyad Initiative, and this was part of the work that Expecting Justice supported us directly in, is creating these connections where there's an opportunity to have bidirectional feedback. So whether something is happening that is positive or negative, we have an opportunity to sit down with staff and high enough ranking staff in the hospitals and tell them, okay, my client Marna came in and was working with your nurse Amy, and this happened, whether it's good or bad. So we don't know what happened. The client is saying they were disappointed or unhappy and whatever, and we're trying to get answers. Or Nurse Amy came in and she was absolutely wonderful. She spoke to the client, the partner. Everyone felt very relaxed. And how can we repeat that? And we find that to be really, really helpful. Now, there is, times where there's pushback. There are times when the providers do not want to hear what we have to say. There are times when they come to us with critical feedback as well. But I consider that an opportunity for us to learn and grow. So I would say, if you would like to, if you have that opportunity to connect and have connections within the medical institutions, if you have, working relationships or you have someone you could talk to figure out how you can do that. And also what we do advocate for is making sure our clients fill out grievances if they have a grievance, and try to support them in the follow through of that. And a lot of times, things happen to you in medical settings and you're not even sure what happened. You don't necessarily know who to talk to, and you're left feeling whatever feelings you have behind that experience. And we're helping to make sure, like, if you want to file a grievance, not only will we talk to our champion dyads, but we'll make sure that that grievance goes through the process, and so that's one of the ways that we have been able to support our clients in any issues or concerns that they have within the medical institutions. Thank you.
Thank you so much. Kefri?
Yeah, I absolutely agree with Marna and what you just said. It's so important. I mean, first of all, we want to support the doulas in their experiences as they're navigating these systems. And so the mentorship part is extremely important, and the peer support, the community care and self-care models, because the burnout from experiencing this vicarious trauma is extremely real. And so the mindfulness of the doula caseloads, their personal family life balance, making sure there's backup doula care, self-care, mental wellness check-ins. All of this helps to support them as they go through these systems and are come up against over and over again this harm. And when we really hold our stakeholders accountable, the birth centers, the clinics, the hospitals, for how the doulas are treated as part of the care team, we can maybe support and prevent the doulas from experiencing higher levels of harm from here. So it's both. It's dealing with the doulas and having the doulas be a part of program creation, so that the program actually represents them and represents their true calling. And this is what's going to be standing really strong within these hospital systems that aren't going to stop doing what they're doing, right? So basically it falls back on us to make sure that we're advocating for the doulas and our programs and our clients simultaneously. I mean, that has to be built into the program from the beginning, right? So it can't just come later. It has to be from the very beginning, and hopefully that can support and address these harmful systems.
Thank you. Priya?
Yes, just to add to that, for folks who are listening in who may be building their own programs, like this is where I think like a payer or provider advocate, like your support, can really help with that accountability piece. So, you know, similar to I think what Marna was describing, we went in before the program started to like introduce, you know, so can we all meet in the light of day before it's like a birth emergency or in the middle of the night, right? So you build connections first. But then also that there is accountability, and, you know, like in our case, when we do identify incidents of like racism, poor treatment, disrespect, bias, either to a doula or a client, like there are pathways for grievances, complaints, you know, through health plans. Like that is part of our job. So I think rely on your, you know, clinical health plan, institutional partner to help with the accountability. I think that's part of what we can offer.
Thank you. Michelle?
Yeah, I just wanted to add, you know, understanding that, like, you know, we are alternative, like holistic care providers, right? And so when people talk about integrating doula work or birth work into these systems, you know, they say integration, but what they're actually asking is for us to assimilate into a system that we don't necessarily fit in. And so that is what we need to address. If a system wants to offer doula support and have a program, don't compromise the integrity of what we do as doulas and call it a doula program when it's really not. And so that is something that we see over and over and over again. They're not trying to integrate us into a system. They're trying to have us assimilate. So like Kefri mentioned earlier, some of the herbal remedies and things that we use, placenta encapsulation and things that traditionally you would not see in these types of systems, you know, we're being told that you have to leave that behind. But we know that these are the things that our community wants and that they need. And so a way to make sure that we can still do what we need to do, like Marna said, and so many other people said, it needs to be community-led. It has to be community-led.
Thank you. Oh, Linda.
Yeah, I wanted to just add to that what everybody said is that what we do is very unique and very special, and it's hard to bring that into these sterile, hard, bureaucratic systems. And you know, one of our biggest fears is that because now there's money on the table, that hospitals may decide, oh, well, we don't need all those Black people running around telling us how we should do this. We can just hire our own little group of doulas and then we'll be blocked out. And it should be a big taboo. We need to make sure that this is about the community and it's about Black people helping Black people. That's why this works so well. Just as I think Michelle said earlier, it's because we look like the people we're helping and they trust us and they know that we're not going to bring them harm. And all of these things together is what makes this work. It's not the fact that there's a person in the room called a doula. It's a person in the room that's called a doula who looks like them, who can understand them, who they're not afraid of, and who aren't afraid of them, to help this process work. So just having something that says X hospital now has a doula program, it's not the same thing. And we all need to make sure to push back against that and make sure that if there is such a thing, then we are still allowed in the door as independent people to come and work in these institutions to help these outcomes stay where we want them to be. Thanks.
Thank you. So moving on to another question. We talk a lot about different ways of measuring success in these doula programs, talk about C-sections and breastfeeding rates, but how do you measure success in doula programs? Marna, and then Priya.
Yeah, I think we measure success in many different ways. I'll drop some information into, I'll find the question and put it in the chat or something, but we measure success in if our doulas basically are feeling like they have the experience and the funds that they need in order to be successful doulas in their career. We measure if the clients have the tools and resources they need to welcome their children into the world with the joy and the pride and the dignity that they want, regardless of their outcome, because sometimes a successful birth doesn't mean the mom and the baby are healthy every time. A successful birth to us could mean that they felt very encouraged, they felt supported, they felt that someone was with them throughout whatever was happening. And as doulas, we often say, we're going to be with you through whatever, whatever happens, good, bad, and different. And that can make the difference. There are people who have very, successful pregnancy and healthy delivery, but were disrespected, weren't listened to. None of that happened, and they're unhappy. There are other people who had, a child maybe born with a birth defect or some sort of congenital disease. And, because we were able to walk with that client and their family through that journey, they felt that they had the support. We were able to know, okay, this child might be born with this, or you might have this thing happen to you, and here are the tools and resources that you'll need afterwards. And so that's a big difference. So measuring that is important. Measuring if the hospital systems are working well with the clients and the doula. There's a sacred birth study that talks about obstetric racism, and we're also thinking about the vicarious trauma that the doulas are experiencing as they might be watching their client go through a situation. They might be experiencing racism too in the healthcare setting, so that's important. And then we also look at, there's a couple others, but we also look at the success, the viability and sustainability of our organization to continue to do what we do. So there's a couple of things that we measure, and I'll drop the link on our website because we have scorecards that measure all of that monthly and quarterly, half yearly, yearly, and you could see the ups and downs that are happening. But we do have measures of success for our clients and our doulas. And we don't think like if the client is successful and the doula is not successful in our terms, then that's not really success, and vice versa. It has to be a doula satisfied with her work, and it has to be client satisfied with their experience. And that ultimately leads to success for us. And if we can continue to provide this program for both the doulas and our clients. Thank you.
Priya?
Yeah, I just want to second that. I think we need to I would advocate like Marna to move away from these like reductive outcomes of success, like cesarean birth. So for example, if I have a patient who's had, 3 prior cesarean births and is going to have another one, does that mean she's not eligible for a doula or wouldn't benefit because she, so I believe that we, like Marna said, we really need to think about like patient reported outcomes of like, what does success look like to a patient and their family, like at that level, and what does success look like for a doula? And that may have to be individualized. And I think right now, there's a lot of pressure on pilots of this, again, what was been said many times, like non-medical, right? Not very clinically defined service on like a very small short list of very concrete outcomes. And I think that's like, it's premature to be at that stage, and also really reductive of like, what is a birth experience isn't just what the mode of birth was, or, how long you stayed in a birth facility or a hospital. Like that is not it, right? It's a journey. And so how do we better measure like individualized measures of success? And so I think California, like, I think it's great that we're like pushing forward to fund doula services through Medi-Cal, and right, I think this is really promising, but we need to like sort of understand that this is like an early stage of this work, and to not be overly reductive or jumping to conclusions about what outcomes and what success looks like.
Thank you. I'll pause if anybody else wants to join that question. Oh yeah, Linda, thank you.
I'll jump in. Along with what Priya's saying, there's a lot of times the doula has no control over what the birth turns out to be. And nowadays, with so many inductions happening to people, it kind of ties our hands sometimes as doulas to support people through that, because we're used to being at a birth for hours. Now we're talking about being at a birth for days. And induction is not a one-day event. It takes some time. I've been in inductions that last 6 days. So when you put someone through all that has to be done for an induction, many times it does end up in a C-section, no matter what the doula does or how we support them. It's just the toll it takes. And maybe they get to the end and the hospital's done everything that it knows how to do and the baby's still in there. So the option is to have a C-section. We don't have control over that. So it shouldn't be, oh, well, that birth wasn't successful, even though there was doula there because she ended up with a C-section. That's out of our realm. And so we have to look at this a different way, and like everyone said, it's more about, at the end of the day, how did the patient feel? Did they still feel supported and loved on and taken care of through this long, arduous process, even though they had a C-section at the end? So I think we have to stop looking at it through such a narrow lens and find a different way to evaluate success for a doula. Thanks.
Thank you. Kefri?
And let's not forget that these programs have been launched and done during an entire pandemic where we've had to switch platforms, deal with our own families, our own health, and deal through an emergency situation, still delivering these services no matter how we can to make sure that our families are served. I mean, how do you measure success through a pandemic? I think you just have to look at the programs. They're successful. Can the sustainability be there to continue to give the services? I mean, the doulas are trained and then they're brought on and then the funding stops or it gets cut or the pandemic happens. It's almost like, when the volcanic eruption happened recently, and I was like, wow, that's like an exclamation point of everything that we've experienced for the last 1 to 2 years in our doula programs. Just great, a volcanic eruption. Wonderful. It's a beautiful metaphor. So the success really lies in those doulas and in the clients and in the real life humanitarian aspects. That, thank you, Dr. Priya, so much for bringing that up. We have to really shift at how we measure these things. And that means this advocacy starts in the institutions that are funding them and that we will be cultivating these relationships with, because otherwise the standard way is not working and it doesn't really reflect the communities that we're serving. And then we're not really going to get the outcomes that we want, right? Because we want to save lives. We want to stop the deaths. That's what we want. And we're doing that through thick and thin, but we need sustainability in these programs to continue to deliver these services. And that will be successful. Let's keep bringing the services to the people. I would like to see that as a measure of success.
Yeah.
Sorry, didn't want to belabor the point, but I just think, like, I don't mean to say, and like, I know there's people probably on this call listening who are interested in evaluation, and I want to encourage them to think through, like, what else should we be looking at, right? Like, what are new measures? Like, we know, I serve on one of California's maternal mortality review committees, and time again, we hear the patient knew, I knew something was wrong. They presented for care 1 million times, right? Weren't heard. And then there was a poor outcome. So not to say, I think there is value in being heard. And I think I just want to, it's not that there aren't outcomes that we can look at. I just think we need to really think about that more. And hopefully there are people listening today who are interested in that space, right? To say there's definitely value. We're just not at the point in our medical model of thinking where we're measuring it correctly. I think there is a lot to be learned.
Thank you. So I think we have time for one more question. So how can state agencies health plans, and payers lighten the administrative burdens for doula programs. We heard a lot of this in our challenges, that the paperwork, data collection, billing is just such an administrative burden for doulas to take on when they're already taking on the birth work. Kefri, do you still have your hand up?
Oh, my hand was okay. Let me put my hand down, but I definitely have an answer for that. You can properly fund the staffing and the administrative aspect of the programs. If that's so overlooked is how we are supported funding wise. And as so many of these pilots were being created, and we've had to switch and change our methodology, switch and change how we're administering these things, and how the staff that we need to help us as the burdens for data collection and the demands, because they'll change and shift during the actual pilots, during the programs. So we need proper funding for the data collection, for the billing, for the data design, and et cetera. But also, if there are ways that the funders can share resources. Can they implement trainings for the organizations and for the doulas? Can they take on some of these burdens? That would be amazing. And also not assuming that just because you've got these amazing birth activists and people who are about to produce your program with you and collaborate with you, that, everything is just taken care of for you. I mean, that's a huge assumption, that they've made, and that these doulas, these are first times for these pilots, are many first time pilots, and so the doulas need a lot of support, and there should be a lot of compassion and collaboration and sharing of the burden, and really tapping as many resources as you can and bringing them into that project so that the burden is entirely on the organization. So I just think even having this conversation, because a lot of times things get thrown at you like, we should just manifest it out of thin air for you, and there's a lot of tap dancing, I feel. And so if we could lower some of those expectations and share resources and properly fund.
Thank you. Marna? Oh, you're on mute.
Sorry, I'm in agreement with Kefri, and also speaking from an organizational perspective. I mean, I think it is important, like if people are going to contract, especially in this piloting moment, to tack on an administrative and a quality assurance and monitoring and controlling kind of stipend. I don't know what you would call it off the top of my head. It's like leaving me, but there should be something to adjust and account for the fact that this is exploratory and iterative, and the things that we start with may not be the things that we finish with. And, considering all the things that Ms. Kefri said around the different types of ways that we could bill, I think that there needs to be money put aside, a line item on a budget that says, we're going to give this money to the organizations that are providing these services to help figure out what does the billing look like ultimately. And then I will say, what I haven't heard is a way to make it work for the independent doula. And that I feel is, from me being an independent doula, it feels not great to think about what is going to be needed in order for me to qualify and bill for something, and the rate. So I just want to speak out. There's one thing for the organizations that might be easier. It's another thing when you're talking about the independent doula. And if we don't address the independent doula that's not working with an organization, then we continue to have this disservice to a certain sector of people. Thanks.
Thank you. Michelle?
I think Kefri and Marna kind of covered what I was going to say mostly, but just thinking about the amount of technical assistance and support that was needed by the doulas, right? And so, earlier I mentioned about we had a cohort of, I believe, 14 when we started the pilot. And so, throughout the pilot, 14 doulas that served all of Los Angeles County. And so these are people from different walks of life, different backgrounds, and different skill sets. And you're asking them all to come in and do something, again, that's exploratory and new, and not the way we traditionally work as doulas, right? And so what I found was that it just didn't work for everybody, right? And no, shade to this doula. You're an amazing doula, but you have to be able to do this technical part. And some people just are not tech savvy, right? But that does not mean that they should be left out as an independent doula if they're not a part of an organization. There has to be some type of structure, some type of umbrella to be able to support the independent doulas, because, you know, we get a lot of conversation about certification and about, you know, these things that we want doulas to do. But, you know, you go back to, like, you know, the grand midwives and things like that. And, you know, this was something that was passed down generation to generation. Like, I didn't learn how to be a doula because I went to a doula training. I was born this way. I was born into this. I just happened to have the technical skill. I just happen to have a medical background. But for those folks who are just doulas at heart, but they don't have the technical skill, we have to be able to support them to still be able to work and be compensated.
Thank you. I'm gonna give Linda, you have the last word on this question.
Yeah, I just want to throw a little humor into this mix, as I tend to do. And it's like, I think we've, as Black women, made these funders and stakeholders expect more than they should from us, because as Black women, we'll make this crap work. We'll make it work. You give us $100,000 and we do $1 million worth of work. And that has to stop too. You know, we have to, when we're getting funded for this stuff, you have to understand that we need the money to do it correctly. But we'll get it done. And everybody on this call has done it. But it's hard. It causes more stress than necessary. And so we need to get funded, just like you fund, I don't know, whoever that's doing something that's not nearly as important as birth work. And we need to get money that will fund all the stuff that you're asking us to do. If you need to give people iPads or computers or, you know, whatever, so they can do the technical stuff and have the applications, then put that money in the budget for us to have it. Because we can't, you know, we can work our Black girl magic, but, you know, sometimes that gets hard and unnecessary. And we want to get funded just like you fund white organizations and just give them millions of dollars, you know, not 100,000 to do $1 million work. So we need to keep that upfront and real, because this living on scarcity is not what this is not what we're about. We want the doulas to make a living wage. We want them to have what they need to function properly. And this can all be very, very successful, but it takes money and it takes time. And we have to have both in order to get it done. We can't be given $100,000 and say, okay, this is going to last for a year, and after that, good luck. That's not the way this works. You know, people keep having babies, and Black women keep having babies that need to be supported. And so if you want these things to be successful, if you want to see the outcomes to be raised up and stop killing people and making people understand how birth works, we have to have the money to do that, so that we can fund, train doulas to work in these bureaucracies that you're throwing us into. Amen.
Amen.
Thank you. And thank you all of you for your answers in this part of the Q&A, and the folks who sent in the questions. In the spirit of sharing the heart work, we want to shift into some story sharing from our panelists. So can each of you share a favorite, memorable, or significant story from working on your pilot? Who wants to go first?
I will.
Okay, go.
So of course, you know, there are many stories that, you know, had us like crying happy tears, right? But one thing that happened more than a few times was that getting feedback from like nurses or providers, right? After having like, you know, a client who's in the program with a doula supporting them, and they saw something amazing that they've never seen before, or they have a newfound understanding about what doulas do. And I think like the most amazing thing was having a couple of nurses say, I want to be a doula. How can I now be a doula, right? And so this is like, you know, this opened her eyes to something. Or, you know, a nurse who was pregnant, then calling and saying, can I get a doula from this program? Like, this is what I need, this is what I want. And so, you know, again, this is like putting a spotlight on what we do and showing people that, you know, this should be accessible, can be accessible, and how it can improve like their birth outcomes. And so, you know, the AIM doulas, like some of them worked at very, very high capacity. So we had a minimum expectation of 2 births per month. But we have like some senior doulas who just, because they're amazing, they did 6 or 7 a month. And it's just kind of like, you know, to put it into perspective, to understand that this doula was requested so many times because so many families were impacted by the work that she was doing. And then also having to, you know, be mindful of the fact that she's working at this capacity and not asking her to take a break, but insisting that she took a break to take care of herself. And so these are the types of things that, you know, people don't think about on the back end of what's going on in these types of programs, but being able to just kind of, you know, manage that was something, even though I was actually actively doing it, it was still very amazing to see how everything panned out.
Thank you. Kefri?
Thank you, Michelle. So trigger warning, because there's some difficult circumstances why our doulas got named the frontline doulas, because they're in these birth streets, they're in these trenches, they're doing the work that you don't think you want to do. But they showed up. And one of the awards that were given to a beautiful Black doula from one of our programs of Black Women Birthing Justice, her client's husband was murdered on the front porch before she gave birth. So having the doula there to support her through that trauma and having a support person that could emotionally hold the space, spiritually hold the space, and not be alone, and support her family in whatever way she needed to, was to me one of the biggest blessings of being able to support that doula and giving care to that family. These are violent acts that are committed all the time. And we're just talking about what we think hospitals or systems are doing, but it's also things that are happening directly in communities that can't be ignored and that are really causing serious harm to the emotional body. And there's a child that's also inside the womb. So this child is also affected. So the doula giving services to the mother-baby diet is incredible to meet them exactly where they need it, not just have to be through a program that was directly given support to the doula so she could give care. So it didn't have to be under any rules, under any data collected, under nothing. She could get the care that she needed. We have extreme social and emotional high needs clients, multiple unhoused clients with histories of mental illness. So the doulas would give services in parks, in cafes, in cars, wherever the client was, the doula met them where they needed to be. Domestic violence, but we had one case is very extreme where the doula recognized that the potential dangerous nature, not just to the mother themselves, but to them as the doula. So at that point, they reached out to the mentors and to other doulas and team members so that a safety plan was put into place, a contingency plan was put into place. So if that abusive partner followed her to the community space, that the security guard was alerted just so that the client could have a prenatal visit. And another doula agreed to meet her there at the prenatal visit so that that primary doula had support. So there was a plan and there was group care and they're willing to support anyone and everyone so that the families could get the doula services. So sometimes doulas have to be in extremely hostile environments and not just those that are present in hospital settings, but potentially from partners or families and et cetera. And so that's why they need the support and the funding and to be paid well, because they're out here really doing the work, it's not just a hypothesis, it's really happening.
Thank you. Marna?
Yes, thank you, Kefri. I appreciate that. I've personally experienced those things with clients and I've seen it happen. So I appreciate that. And I want like to actually, most of my joy has been with working with the doulas and not to focus on the families because I think that it's been wonderful to see, especially when folks weren't sure what a doula was. And then in the end, they're like, oh my God, now I want to become a doula. That's amazing. And it's really, really a joy to me to see that people can have jobs in our organization working as a doula, getting paid. And working to support doulas and get paid. We've had folks that were able to leave their jobs. You know, we've had doulas who started with their high school diploma or their GED and saw all of the reproductive justice career pathways for them and decided they think that they can go to college and they can achieve, you know, this or that thing to become the community researcher, to become the statistician, to become whatever. We've had a number of doulas go on to become nurses and or start the training for nurses and nurse midwifery, and people decide to pursue their dream to become the doctor, you know, the OB. And so that's really exciting when you look at community members, our Black and Brown community members who are deciding to move upward into other fields where we need those people of color. We do need people of color in the medical profession. We do need Black and Brown doctors. You know what I mean? We do need Black and Brown nurses. And it's especially wonderful if they have a doula background. So I find that that's, you know, something that just warms my heart that I get to be a part of a revolution in this type of way. And it didn't come from me marching in the streets, but it comes to me, I feel like the change happened because I was able to facilitate, you know, X number of Black and Brown folks into the system. You know what I mean? We like to say we're infiltrating, but you know, that's what it feels like when I can leave and I know that somewhere there are doulas going into medical practice. And that's really special to me. And also being able to work, to actually have a job. There are people now in the city of San Francisco say, I have a full-time job working as a doula. And that's pretty exciting as well. Thanks.
Thank you so much. Linda?
Yeah, we were talking earlier about measuring success. And I work with an organization through the county. They have a Black centering program that's for, by, and with Black people. And the first cohort that they went through, there was a person in it, and she was told from all the, you know, they saw she had to see doctor and a midwife at the same time. And, you know, she'd go to the doctor and they'd say, oh, well, you know, you're probably going to have a C-section because of your BMI. And I doubt that you'll be able to push your baby out. And, you know, she'd go back to the midwife and they'd say, yeah, you can push your baby out. And so long story short, she did push her baby out, and she had a doula that I got for her. And she had some complications afterwards, serious complications. But at the end of the day, you know, when she came back to tell her story about her birth, she was like glowing, even though she was very, very sick, because she said, I knew that I was cared for because everybody looked like me. You know, the doula looked like me, the doctors looked like me, the midwives looked like me. And so I felt like I was going to be okay. And to me, that's the success of any program that we're trying to do as a community doula pilot, to have people, even though they have maybe not the best storybook birth, they feel like they've had a good outcome. And in this program, what we're going to be doing is we're providing a pathway for the people who've gone through this centering program to become doulas. So I'm going to be training 6 of them, because, you know, this came about and we said, well, but wouldn't it be great if we could get them to be trained to come back and be doulas for the people that are going through the program. And I was like, yes, this has been my dream forever, to have Black women from the community work with other Black people from the community. And so before we even told them, at least 3 of them called and said, Miss Linda, how can I become a doula? I really want to be a doula, you know? I was like, oh, my heart, stop. You know, so I just feel like we're planting seeds that are going to grow into mighty oak trees. And we have to make sure that this all works well, because it could become a real show. And we don't want that. We want it to be successful. We want it to be empowering. We want it to be a really good thing that happens for the community, not something that destroys everybody, or it doesn't work because they're not paid well, or for whatever reason, there's too many paperwork, or takes 6 months to get paid. We don't want any of that. It doesn't have to be that way. If people will just listen to us and try to put into place some of the things that we're trying to tell them that we know will work.
Thank you. Deidre?
Well, these stories, I love the stories. They're my favorite part of the panels and part of this particular discussion. But it is just incredible to witness the space that we get to hold on multiple levels, not just for the families, but also for the doulas. I love hearing these stories where the clients want to come back and serve their communities. I've also had a few stories like that. But the story that I want to share was of a birthing person who gave birth last year, who this was their third baby. And I had the privilege of attending their first birth and debriefing with her after that first birth, the care that she received. I mean, she had the baby, everything was fine and normal. The outcomes were ideal. But the care that she received and the way that she felt that she was treated was disrespectful, and she just had so many questions about what her experience was. And so last summer I got to support her and her family in their third birth, and she was a recipient of a program where in the past she had to consider, how do we save for a doula? How do we pay for, or what does it look like to cover out of hospital birth? What are some of my options in terms of education? And so this last birth, she didn't have to worry about, and I know somebody had mentioned that earlier, like if we can cover the cost of the doula services, then the families can spend their resources in other places, things that are also more important because having children are expensive. And so because of the program, she was able to not just have a Black doula to serve her and her Black family, that came at no cost to her, but she was also able to then find funding and resources to have a Black midwife to deliver her baby or to give care to the baby at home and her. And to witness that, to be a part of that, I think it was even my first time being part of an all Black birthing team as well. And so it had a huge impression on her as the birthing person, but even me in this work, being able to be part of that team was so incredibly uplifting. So it was really amazing to be able to know that she was able to get that because of the programs that we're offering.
Thank you. Priya, you have the last word on this.
Oh man, okay, I'm not a doula, so my story is different, but I've attended some births, but I just have a story, I think, for like payers or provider groups or like the system folks who are participating today, who are interested in this work. And I learned from our experience in the Inland Empire that you need to like approach this with humility. I am an OBGYN. I'm not a doula. I do not know what doula care is about, right? I am not the expert. And so realizing that the way we started, and also like in your part of California or the world, like there may not be a ton of infrastructure or existing work happening in this space. So you may be like approaching it new, which is sort of how I felt in the Inland Empire. And so what we did was basically, I mean, literally said through social media, are you a doula in the Inland Empire? Do you want to serve Medi-Cal members? Will you have lunch with us? Like, we will buy you lunch, and please just come talk to us and like learn from that. You know, we approach it with humility. We said, we don't know this, like, and ask questions like, you know, what would this look like? How much do you think you should be paid? What should that look like? You know, how do you do this work? What's a reasonable like coverage area? Do you cover for each other? You know, and like, I think just you if you approach this work as an outsider from the system with humility, I think it will go a lot farther in like having a successful program. I mean, that's how we should approach everyone, right? But like, this is like so important. And I think as this becomes like a benefit, and as like state agencies or, you know, federal agencies approach doula services, like I'm trying to really share that story of like, if you start with humility and approach this, like knowing that you're not the expert, you know, I think you're more likely to be successful.
Right, thank you. And thank you everybody for sharing your stories and providing so much labor here. We're going to switch to Ashanti for her visual art of the meeting. Let me spotlight her.
Hello. So I'll just walk you guys through quickly. Oops, excuse me. So we start here where you guys opened up and you talked about a variety of things. You guys had different questions, but some of the things that you guys talked about were compassionate care. Does everyone see me?
Mm-hmm.
Everyone hear me? Okay.
Yes.
And then you guys just talked about how it's hard work to be a doula and just having the importance of doulas being compensated for the work that they do. And we talk through, the burden that we perhaps put on doulas to do all the system changing, doing the individual check-ins, considering, the trauma and aligning people to different resources. And then you guys started to talk about mentorship, what that meant, what that looked like, the importance of feedback, right, both ways, and how you can grow from that. And just talking about, keeping our stakeholders accountable, at the same time advocating for the doulas and for clients. And I think what was really important is, recognizing you guys are holistic, or doulas are holistic caretakers, and not to fall into assimilation, to keep in mind who you truly are and your purpose. And then you guys just talked about, measuring, how do you measure success, and just remembering that it's human-centered, right? And that's what we want to focus on, is how do people feel about the work that they've done? How does the client feel? And then you guys also talking about sharing resources and also, having everything properly funded, but at the same time, you guys made the point of talking about the independent doula who also needs structure and support. I'll turn it back over to you, Amy.
Thank you. 1 second. All right, let me see if I can go back to gallery view. Yeah, so thank you so much, Ashanti, and thank you to all of our wonderful panelists for all of their work in even just bringing this to us, aside from their normal work that is also so incredible and important. And thank you to everyone who joined us. We would like to remind folks that in the coming weeks, we'll be sharing the webinar recording, Ashanti's visual recording and her art, contact info for some of the panelists, and our finalized documents that we sent the drafts for earlier this week. In the spirit of the discussion we've had today, particularly around fair and equitable conversation, we would like to ask that you please take these principles into account if you're going to reach out to the panelists today and ask them to provide any thought labor for you. And if you would like to continue this conversation, we can provide you with our emails as well, and we have a listserv for folks to join. So thank you so much to everybody who has joined us today, and we will close out our webinar.